Yes, Dr. Rosenzweig-Lipson, is the idea behind calming the hippocampus to just sort of buy some time before the disease progresses, or through this, does it in effect stop MCI from developing onto Alzheimer's?
So it's an important consideration. We actually think that it has the possibility of essentially halting the progression of the disease, and there's a number of different factors that are considered in that. One of which is, as I mentioned, we know that overactivity drives progression of the disease. So if you turn off the overactivity, we think you're no longer going to drive the further progression of the disease. There's actually some really nice data that was generated in the amyloid mice, looking at double-stranded DNA breaks, and showing that this neuronal injury can be reversed by low doses of levetiracetam. And some really nice data now that just came out in a publication showing that that same type of double-stranded DNA break is present as you go from MCI to Alzheimer's disease. And so exactly the same type of marker is now present. We've now clinically known to be present in MCI, and we know that we have the ability to reverse that. There's also data we have looking at markers like reelin activity in the entorhinal cortex and the reversal with levetiracetam of these kinds of synaptic markers. So I think there's a number of places where we can potentially improve and certainly alter, slow, or delay the progression to dementia.
Question in the front.
Yes. So I'm basically here because my mother suffered from this disease for a long time. So as a result of that, I teach a class on how to communicate with people with Alzheimer's that I wrote. And so I'm here to learn more. And during that class, I educate people on the medications available to them. And generally, the medications treat the symptoms. And as you mentioned before, we don't have any new medications on the market. So my question is directed at all of you, I guess. So it seems that we're focusing more on the brain, which is great, and going more after the actual disease, as vast as it is, to try and diagnose, and less on the symptoms like anxiety and would that be accurate?
So at least, most of the companies that presented were focused on the circuitry and the synaptic health, which could have multiple outcomes. And trophic factors, the systems that we target, actually interact with neurotransmitter systems that also impact behavioral endpoints.
Absolutely.
And the biomarker that we also use in the EEG and ERP in neuropsychiatry, which focuses on more behavioral changes, has huge correlation to these changes. So I think that neurodegeneration and loss of synaptic density is in the core of all of these endpoints because you're recovering the circuitry, which we think and hope that ultimately it will have different outcomes. Now the focus, I think that the most clear connection to the disease is cognition and behavioral and functional endpoints, and you still need these endpoints to get the label for Alzheimer's. But I think hopefully now that we're not focused on one component, the protein pathologies, that we're thinking about the outcome and what this could translate as a clinical endpoint. At least the way that we're designing our phase 2-3, we're including behavioral endpoints because we expect that there should be change on behavior. I think Tamara also showed a few.
Yes, we have been reading out parameters of in behavior before we are actually assessing the cognition ones because they are just faster to evaluate, and we can see that we have this effect. So the difference between symptomatic and disease modifying, even the definition of disease modifying, is a little bit different across diseases. In MS, a treatment like fingolimod is supposed to be disease modifying, but actually what it's doing is preventing new attacks. And because it's preventing new attacks, of course, the disease doesn't progress in the same way. The way that it has been defined in Alzheimer's disease is more in function of exactly how the decline was happening and what happens with the control group. But I think in the end, we would like to advance on all fronts, not just, of course, if you get, you want the symptomatic part to be treated.
Yes.
So, you hear me? Can you hear me now? Good. Just as a brief overview, there are 5 or 6 drugs on the market today that generate about $6 billion a year. Those are all based really on neurotransmitter regulation. All of them are increasing cholinergic, such as Aricept, or decreasing glutamatergic. In my understanding, my experience, none of those drugs have a long-lasting impact. They have a transient impact, and it's usually modest, so you can't expect too much from those. All of those could impact on some of the parameters you just heard about. But what you really need is something that's going to actually modify the progression of the disease. Now, when you hear about trials that say we're looking at early Alzheimer's disease, in my opinion, that's almost impossible to diagnose. Most of these patients have mild cognitive impairment or slight changes. The problem with early diagnosis, at least in our hands when we do autopsies, we've done more than 150 autopsies, we found that the doctors making that diagnosis of early Alzheimer's disease are making it with an error rate of about 30%. And amyloid imaging doesn't improve that very much. So when you say early diagnosis of Alzheimer's, I have early Alzheimer's, you heard in the movie, for example, I'm Still Alice. She says she recognizes the disease, but in fact, most Alzheimer patients early on don't recognize the disease. They're not aware that they have it. What we really want to go after is something that shows an impact on the progression of the disease. So into 4, 5, 6 years after it starts. Typically, that's what we focused on, partly, not because it's the only place to go, but that's because you can be more definitive in making the diagnosis of what the disease is. Now, in the approach that we've taken, we think that by using severe impairment battery, you're actually assessing multiple different aspects of this disease, including hallucinations, behavioral overactivity, aggressiveness, memory loss, all of the things that you heard about, in addition to some of the more core memory loss, dementia aspects that we've heard about. And what you really want to do is see in that multiple score improvement, if possible. If you see improvement, then at least suggests that you may actually be treating the disease. And we're hoping that that's what we're seeing, and we're hoping to be able to bring our drug on the market to address some of these problems within the next 2 or 3 years.
What are more important things that you hear more about the memory loss?
Well, that's a good question. So, one of the things I wanted to ask him is, I think, no disrespect, there's a danger in some of the information that you bring to the table, because the biggest question I get in class is, there isn't a cure, there isn't anything to stop the progression, and I think when the commercials come on and they say they're slowing their progression, or they have, sort of the end-all solution, and I'm all for having a cure in our lifetime, having watched my mother go through that. So for me, to answer your question, I want to be able to tell the students whose families suffer, or when I donate time to the community, I want to be able to give them a solution so that they know when their family members are suffering, and my friends are going through that with their parents, to say, hey, there are drugs coming on the market, or there are solutions coming on the market, to say, okay, it's not necessarily only treating the symptoms. There are researchers working on treating all the different aspects of the brain, of the heart, of all these different medical, geniuses working together to make this happen. And again, I meant no disrespect to what you're offering, because I think you all have different things that you're bringing to the table for different reasons, all different kinds of research. And I'm thrilled to be here today to learn the things that you're offering to us, because as an educator, I'm educating on communication and just mildly bringing to the table what's on the market. I have no idea what's behind it.
To begin with the fact that there is no drug on the market right now. So, this is the reality.
It is.
And there's no drug on the market to actually treat the underlying disease. The FDA has not approved that. And that will be a major step forward. When one drug, and maybe hopefully several other drugs, will start to do that. But right now there is none. They're just symptomatic relief. The last drug that was approved was in 2003 with memantine, and as you probably know, that oxybate, it has some of the same properties you heard today, reduces overexcitability, and actually, sees. But when we say slow progression, that's easily confused with slowing the decline. It's not slowing the actual progression of the disease, because while the symptoms are maybe slowing, delaying the decline, they're not actually slowing down the disease. And we know that because 3 weeks later, 4 weeks later, it's not having any impact at all. So it's not slowing the actual progression. But that's the fact. And, I think it's important, in my opinion, not to raise false hopes. At the same time, what you said before is, I think, on target. People, drug companies, you've heard some of them, are working on something that will actually treat the disease. But we don't have it yet.
We're going to take the next question, if that's okay, with the microphone.
Thank you all.
Me? Yes.
Yes. So this is actually a question related more to the mechanism rather than the drug. So first, Dr. Tamara Maes talked about aggression can be brought down. I might get the drug wrong by CAMPB. In mice of different genetic background, different levels, lab mice particularly, of aggression. So do you see any countervailing equivalent molecule varying in those mice? That's one part. In normal neurogenesis, normal development of the brain, initially there's a pruning of synaptic connections. Dan Alkon might address this. And on the other hand, now we know, coming from pioneering work with Dr. Jonas Friesen and Karolinska, it's developed all the way on, that the stem cells that are continuously producing new synapses. Where do you see Alzheimer's fit in those extremes? So either one of you.
If I may, I can start by saying that it's always important to distinguish between what's happening in mice and what's happening in people. When you talk about neurogenesis, mice have a lot of neurogenesis. The human brain has very little neurogenesis. More importantly, as far as I know in the literature, no stem cells that have actually been put in the brain actually form integrative networks that are meaningful in information processing. So stem cells may be very important for other tissues. I haven't seen the progress, the potential in the brain tissue. And aside from the difficulty of getting it in, but also very few. So that's why we've emphasized synaptogenesis rather than neurogenesis, because what we hope to do is to take neurons that are dying, revitalize them, getting them to set up the synaptic connections and reform them. That way they can be integrated with other networks that are still there. Frankly, if you had asked me, I would have said 15 years ago, that's just not possible. But what we see is that some of the information processing really precisely allowing the animal to navigate through complex tasks is restored. That means it's not the same synapses that are being restored. Other synapses are coming on board, but yet those synapses are taking over the function of those that have lost. So there's enough, in my opinion, redundancy built into the brain systems that it allows alternate pathways to take over some of the information processing. One other point, you mentioned pruning. I think it's very interesting and important to recognize that synapses are eliminated as the brain forms in our 1 and 2, 3-year-old. There is a lot of that pruning and selection process, and there are certain factors, one of them being PKC-epsilon, that are paramount in that. What I always thought was that by the time we reach maturity and older age, that those factors are gone. And in fact, they are deficient. They are down. But what I didn't think was possible is if you restore those, bring back introducing some of those into the same need, that you could restore some of that flexibility. I think that in the case of Fragile X, in the case of Alzheimer's disease, in the case of other disconnecting diseases, I think what it suggests is that you're not eliminating, it's not the elimination, but the reformation that's critically important. When we did Fragile X, we were and still most interested in Alzheimer's, when we did Fragile X, we posed it as a, what shall I say, a Popper-esque kind of hypothesis, that we wouldn't be able to sustain the hypothesis with Fragile X. Because, why? Because in the case of Fragile X, the children and the mouse models actually come into the world very shortly thereafter. The synapses are all screwed up, they're all dysfunctional. If you look with electron microscopy, they're all misshapen. So they're all, the cow is already out of the barn. What are you going to do about that? Well, at least with our therapeutic approach, it seems that you can actually reshape them. You can get them to reform in a certain way. And that's potentially amazing, because that means that even if the cow's out of the barn, we can go backwards in development. But I don't know about the process of elimination. You know, originally it was suggested that synaptic elimination is critical, pruning is critical for all brain processing. I'm convinced that would be true, that is true for early development. I'm not convinced it's true in our mature brains.
Question in the center?
Maybe you repeat it, because everybody has forgotten it.
So basically, I can't remember the drug that you use, I think it's
Confidence.
CAMPB, is that correct?
Yeah, sorry?
The inhibitor of aggression,
It
and
is,
genetic medicine?
yes, it is targeting LSD1.
Right, so that's good, thank you. So it reduces aggression in this white mouse that you had.
Yes.
I think it may be Balpsy, I'm not sure which one it is.
Yes.
So Balpsy are normally
No, they're not BOP-C, they're SAMP8.
Okay, I won't claim to be an expert on that. But I do know
Yes.
that different lab lines particularly have different levels of aggression. And even in the wild, in natural hybrid zones,
Yes.
there is aggression. So do you see any candidate molecule that regulates, I'm a big more proponent of Darwinian natural variation in any system, be it the maintenance of genome, genetics, other biologics. So do you see any equivalent molecule in that space or in the laboratory space that is the equivalent of your inhibitor? Making nice docile,
No, we study
making more aggressive.
mostly, of course, molecules that we make.
I see.
Yes. I think what you're saying is interesting. I mean, in the sense that you have different mice behave differently, and even within the mice, for example, SAMP8 mice, the males and the females behave
Correct.
differently. And but what we see is that they both have behavior alterations.
Yes.
Which we are modulating, which we are improving, meaning in this case, making them react more like the wild type strain,
Yeah.
the reference strain in that model. I mean, you can contemplate what is the use of aggressiveness, no, as a species.
Survival, right?
And survival. But I think there are grades, and probably the grade that we were seeing was not very convenient, not in the social interaction of the females, nor in the aggression of the males. And what we are looking at in the clinic is pathological behavior, and it appears to be that we are improving that pathological behavior.
Final question for the session, please.
For Dr. Rosenzweig, with the hippocampal hyperactivity, are there any clinical indications of that per se, or when that hyperactivity should drop off? Are there any clinical correlates? And then also, as far as Keppra is concerned, is there something special about Keppra or all anticonvulsants?
To your first, I think we know that there's this drive in hippocampal overactivity that occurs at MCI. I think what happens, and we don't know where that changeover point hits, but as there's a loss of hippocampal neurons, they're just fewer to become overactive, and so you lose that overactivity at some point in the cascade. Where that time frame is hard to identify. We think it's probably sometime after the crossover to mild Alzheimer's. But we're keeping an eye on some of that as we're doing more work in the field. Your second question.
Why specifically Keppra?
Okay, so yeah, So actually, Keppers an atypical anti-epileptic. It's not the same mechanism as a lot of the other ones, and a lot of the other anti-epileptics don't do the same things. So it's not that this profile is an anti-epileptic profile. We know that there are a lot of anti-epileptics that don't do it. So this is unique to these SP2A inhibitors, which is the class that Keppers are part of. And so I think that's, an important consideration. The other thing that's important to note is there's no overlap in the doses. Okay, so I talked about low dose levetiracetam being effective. High dose levetiracetam is not effective in mild cognitive impairment, and high dose is not effective. There's no overlap in the doses. So low doses aren't effective in epilepsy. High doses aren't effective in mild cognitive impairment. So it's really important to get the dose right. In fact, if you look at the exposure that you need to see the effect, whether it's in a mouse, in an Alzheimer's mouse, in an amyloid mouse, a tau mouse, an age-impaired rat, or MCI, it's the exact same exposures that you're needing to see efficacy, and it's the same exposures where you lose efficacy, where you get too high. So we know that there's a really important balance there. And I think if you think about using an anti-epileptic, when we're using it at the low doses, what we're doing is we're turning off the overactivity of the synapses. We're actually turning back on the activity of the anterodic cortex. So we're actually restoring the entire network circuitry and function. You start to get to really high doses, what you're doing is kind of dampening the brain. And the last thing you want to do in Alzheimer's disease is start to dampen the whole entire brain. So I think what you really want is this exquisite circuitry that you're restoring, and that's unique to this type of class.
And what are you finding is the duration of the treatment? Can you stop and end the mild cognitive impairment, or?
We first have to do the clinical trial at MCI over the 18-month period and see where we are, and then we'll be able to do the further experiments to see whether we've halted, slowed, delayed, where we fell on that curve, and we'll also have a better understanding of stage, where the people were when they enrolled. So they start at a milder stage of MCI, they start at a later stage of MCI. But there's a lot of work to be done that we're too soon to answer those questions.
Thank you so much to all the panelists. We're going to take a break for lunch now until 1:30. Thank you again, everyone's welcome to join us.